Sorry about this. But they sent you.
Okay, I'm sorry.
Can folks hear me? Okay. Sorry for the delay. I wasn't able to get in. I was having a little trouble in calling around. So I'm appreciative for the folks that are working with us and getting things set up. So I apologize for the delay, and I thank you for your patience. So if we're ready, I believe we're recording. Are we recording now?
Yes, ma'am.
Thank you. All right. So I was getting in on two different computers so that we could, I can make sure that I was there. All right. Let me just move this out of the way on the screen. So welcome everyone to the 6th session of the webinar series on genetic services in Appalachia. We ask you to mute your microphone for the talk and place any comments or questions in the chat box. And we should have time to ask some questions towards the end. At the end of the session today, we will ask you to complete an assessment to give us feedback. As you know, our aims include to develop a research agenda for genetic services in rural Appalachia. Each month, we've been having speakers who are working in genetic service provision to the medically underserved populations around our area, with a focus on setting a research agenda in rural Appalachia. I would now like to introduce our speaker,
Research in Appalachia, America.
And I'll just ask everyone to mute their microphones, please. Just give it a double check. Dr. Graves received her PhD in clinical psychology from Virginia Polytechnic Institute and State University and completed postdoctoral training at the University of Kentucky. She is a tenured associate professor of oncology in the Cancer Prevention and Control Program. In January 2021, Dr. Graves began serving as the Associate Dean for Faculty Development at Georgetown University Medical Center. Her research focuses on cancer survivorship and translational genomics, with a particular emphasis on community engagement and addressing health disparities. Dr. Graves is co-leading an R01 funded project to explore symptoms experienced by patients diagnosed with thyroid cancer who receive radioactive iodine treatment. She is site PI on an R01 to evaluate an expressive helping writing intervention to reduce symptoms among patients treated with stem cell transplant. Another area in which Dr. Graves conducts work is raising awareness about genetic counseling and testing in underserved communities, which is going to be the focus of her talk today. She is a multiple principal investigator on an NCI R25 award to train community health educators, patient navigators, and promotoras about hereditary breast and ovarian cancer in Latinos. This training project is called Árboles Familiares, family tree. And so I also know that Dr. Graves has done a fair bit of work with the Appalachian population in Kentucky. So we look forward to hearing her presentation today. Are you ready, Dr. Graves, to share your screen?
Thank you so much, Dr. Kelly, and really excited to be here. Yes, I can share my screen.
Thank you.
See, can everyone see that? Okay. Great. All right. Well, I'm really excited to be with you all today, and we should have plenty of time at the end for questions and answers. No formal disclosures. This was taken when we were at our most recent Árboles Familiares training, which was last November, our first in-person training in 2 years. And we had a guest who liked to watch and learn about genetics standing outside. So many of you may be familiar with this translational continuum, But I wanted just to set the stage for us today to think about how some of the basic science genetics work and the discovery of genes related to hereditary cancer is now moving, not only well into practice, but also through ways that we can then bring these discoveries into the community and ideally take ideas and lessons from the community to inform the research and how we deliver this care. Reminder, I'm sure, for this group, but just to put the context that, again, about 10% of colorectal cancers and breast cancers are considered hereditary, with a larger proportion of individuals who are diagnosed with ovarian cancer having hereditary cancer. And again, likely a review for this group, but just to reinforce some of the potential impacts that someone may have if they do have genetic counseling, opt for genetic testing, and then receive a positive genetic test result. So it could influence someone's patterns of their cancer screening in terms of either frequency or type of screening. For individuals who are found to have that positive test result, it might influence uptake of risk-reducing surgery, for example, prophylactic oophorectomy. It might influence in a small number, and we know that this research is growing, but to think about chemo prevention through use of selective estrogen receptor modulators or aromatase inhibitors. For some, it might influence how they think about their lifestyle, for example, reducing alcohol intake to also reduce the risk of breast cancer. For individuals who have been diagnosed with cancer and then have a positive test result, it could influence the type of chemotherapy that their provider team recommends, or again, the type of treatment. For example, a woman diagnosed with a unilateral breast cancer who has a positive test result may decide to have contralateral prophylactic mastectomy on the other breast. To reduce risk of cancer in that breast. And then, of course, implications for family members. The idea that others may carry this gene and may find it useful to have genetic counseling and perhaps genetic testing. So wanted to set the stage for what we're going to talk about with genetic services and finding ways to reduce barriers of uptake by reminding us that the uptake of genetic testing does remain lower than it could be, both in individuals who are affected with breast cancer and among individuals who are affected with ovarian cancer. And these are some studies from 2019. And so soon after I arrived at Georgetown, one of the projects that I had the opportunity to work on, and this is when I was a project director as an instructor. So I was really fortunate to be able to enter into this study, which was a non-inferiority study where two different approaches to genetic counseling were evaluated. And so the overall goal of this project, we called it the Telephone Genetic Counseling Study, or TGC, was to look at, and this was back in early 2009 and 10 when we were looking at this, is there equivalence between genetic counseling that's done over the telephone and genetic counseling that's done in person? This question, I think, has been answered more recently as well, but this was one of the first studies to do a full equivalence type study of these two approaches. And so the goal, and this work was led by my mentor, Mark Schwartz, but at the time it was to compare the safety. Are we causing any harm if we're not having a patient sit directly in front of us? The efficacy, does it work as well when genetic counseling is delivered over the telephone in terms of patients understanding, if they have any distress, the types of decisions they make about genetic testing. And then another component I won't be presenting today, but it's in the paper referred here, is the cost. The take-home message there is that telephone genetic counseling costs less than in person. So again, this was a non-inferiority trial. We recruited women from 4 different sites. You can see some of the reasons why people declined or were not fully enrolled in the study, and then randomized to telephone counseling or usual care in-person counseling. And we compared the outcomes 2 weeks after the genetic counseling, and then again following receipt of the genetic test for those who were interested in having testing. So the take-home message is here. We did not see any differences in uptake of genetic counseling when people were offered to do the genetic counseling either in person or by telephone. So it was equally accessible and appealing to folks. We did see a slight decrease in the uptake of genetic testing for those who were randomized to telephone genetic counseling or telegenetics. So 90% of those who were in person with their genetic counseling had opted for genetic testing versus 84%. And we can talk about this again at the end. One of the big differences was that when someone's in front of you in the center, they can walk immediately to at that time, the blood draw room to have a sample taken for genetic testing. But with telegenetics, it involved mailing of a kit to obtain the sample. And if everybody could again check their mute, that would be great. So then the other piece was the efficacy. Do we see the same results across these 2 modes of delivery of genetic counseling? And this time point was after the first genetic counseling session, but before disclosure of the genetic testing results. And the yellow framing on the graph to the right indicate the range at which the scores would be considered non-inferior, meaning no differences in this non-inferiority trial. So because the confidence limit does not extend past the yellow range, it was found that telephone genetic counseling was not inferior to in-person genetic counseling on patient satisfaction with the process, their knowledge about what it means to have a hereditary cancer syndrome or be at risk for hereditary cancer syndrome, their perceived stress overall, kind of global stress, as well as cancer distress. Then we looked at similar outcomes after the disclosure of test results, because there potentially could be differences if someone was able to have genetic testing and then how they understood that information or how it made them feel once they got their test results. So again, it was found that telephone genetic counseling or telegenetic counseling was not inferior to in-person genetic counseling on all of the key outcomes that were assessed in terms of physical functioning, mental functioning, that was assessed with a kind of global quality of life type index, perceived stress, cancer distress, and importantly, decisional conflict. Individuals who had the telephone genetic counseling did not experience more conflict about their decisions to have genetic testing than those who had in-person. And so from those results, we were interested in, as time went on and we learned more about genetics and genetic risk, we were interested in extending some of this work to other types of cancers, as well as different levels of risk conveyed. And so I led a pilot study to look at individuals who were identified from primary care clinics for interest and uptake of testing for single nucleotide polymorphisms related to colon cancer risk. And so we wanted to know who might be interested in this type of testing, what information is important to make sure that people understand the information, and then importantly, how we should communicate this information to diverse audiences. And so the protocol was that we would recruit from primary care, and given the at the time relative novelty of looking at single nucleotide polymorphisms, we thought it was best to stick with the in-person genetic counseling for this project. But we've since looked at other ways of delivering information by telephone. Individuals could choose whether to have or not a SNP test. And then after the test results were returned, coming in to discuss the results. And so we worked hard to find ways to communicate this risk. And now when I look at this, many years later, it seems even more complicated than it should have been. At the time, we were working to follow best practices in risk communication. And so describing what the SNPs were, conveying the level of increased risk by showing someone what increased risk looked like versus not increased risk, placing that in the context of the grid with the number of people highlighted in terms of estimated lifetime risk of colon cancer based on the genetics, the genomic profile. Also at the time, we wanted to make sure that people knew that this was, not conclusive. It was still in the research phase, that it was based on only 3 specific SNPs, that we didn't know how other types of colon cancer risk factors related with these SNPs, as well as the limited evidence on risk estimates for individuals who are not from predominantly European descent, given how some of the GWAS studies and the risk estimates were concluded at the time. And so we found strong interest overall in this type of genomic testing for colorectal cancer risk in this, again, small pilot study of individuals recruited from primary care. So not pre-selected for any types of risk factors for colon cancer, although they did have a range of different types of risk factors, both familial risk as well as behavioral risk factors. So we wanted to know, do people change their behavior based on this risk information? Because it was a shorter term follow-up with 3 months, we assessed intentions for colorectal cancer screening, and then looked at reports of physical activity and healthy eating. And we did see that there were some changes in terms of individuals noting that they were going to communicate with their physician about colon cancer risk factors and colon cancer screening. A quarter of them had made an appointment for colorectal cancer screening. And again, we know intentions don't always predict behavior, but we were pleased to see that 100% of the individuals who were due for a colorectal cancer screening intended to have one. So I mentioned earlier we were interested in learning about how we communicate this level of genomic risk to patients. And so I was really fortunate to have a number of genetic counselors on the team, and we audio recorded the disclosure sessions that we had with participants. And then we did a discourse analysis of those genetic counseling transcripts. And Morgan Butrick had some experience. She had worked at the National Cancer Institute as a genetic counseling fellow, and she had some experience with coding these transcripts in terms of labeling verbal dominance as well as turn taking, and used a specific coding program called RIAS to do that. And so we did find that genetic counselors demonstrated greater levels of verbal dominance with patients who were underrepresented in a lot of genetic studies. So Black and African American patients, Latino patients. So I think taking something like this could be interesting to look at other types of populations, rural populations and the like. Is, do we have similar rates of verbal dominance of genetic counselors with different types of patients? And we looked, as I mentioned before, we gave a caveat to our participants about the interpretation of some of the data based on the limited findings for risk estimates based on the genome-wide association study estimates that we had, whereas most of those estimates were based on European descent populations. And so there were some differences in terms of some of the process outcomes, again, by participants' race, in terms of coverage of the topics that we had in our educational materials, the booklets that you saw a snapshot of previously, and then the genetic counselor's ability to adequately assess participants' understanding of the information. And in the bubble, there are some quote extracts from our transcripts. This was some of the earlier work. There's been some really intriguing work by others in the field looking at unconscious bias, not only in genetic counselors, but this has been applied across a lot of different healthcare professionals. And we all carry around these biases. And so thinking about ways that we can recognize our patterns of communication with different populations could be important. So given some of that work and some of my survivorship work that had been in Latinx communities and specifically Latina women diagnosed with breast cancer, we were interested in taking some of this work and seeing what Latina women knew about hereditary breast and ovarian cancer and ways to make connections between genetic services and different types of populations in the community. And, some of the legacy studies looking at differences in awareness about hereditary breast and ovarian cancer by race and ethnicity. But then other work saying that once someone found out about the availability of genetic services, there was high level of interest. So we did some background formative work. This was led by a medical student who was interested in understanding from the perception of patients and community-based members. So we collaborated with a community-based organization here in Washington, DC, and identified women who had genetic risk factors in terms of strong family history or young age at the time of diagnosis or diagnosis of ovarian cancer. And we found that our participants had a generally low awareness of hereditary breast and ovarian cancer. Some had never heard of genetic counseling and many had never heard of genetic testing. Once the concepts of genetic counseling and genetic testing were explained, and this mentee created a fantastic short 5-minute video in Spanish with English subtitles explaining kind of genetics 101, what is hereditary breast and ovarian cancer, what is genetic counseling, what is genetic testing. Our participants indicated they were very interested in learning about this information, not only for themselves, but in particular for their family members, and a strong emphasis on valuing health. Although there were conversations about, that there's other competing priorities as well and wanting to take care of people and not always prioritizing making time for their own individual health. And then we also talked about and asked about barriers to genetic counseling and testing, and the ones that kept surfacing included cost, language barriers, and insurance barriers. And so based on this information and some others, formative work led by my collaborator, Susan Vadaparample down at Moffitt Cancer Center, we set about developing a training program And this is the one Dr. Kelly referred to that's called Árboles Familiares, or family tree in Spanish. And we wanted to help think through ways we could reduce barriers to accessing genetics professionals and genetic services, which are often located in an urban center or in cities, or in larger hospitals, when many people may receive their care out in different community clinics. And so our goal was to create this training program to develop a cohort of individuals who had high knowledge about hereditary breast and ovarian cancer, confidence about how to explain cancer genetics in terms of talking with community members, and identify red flags for hereditary breast and ovarian cancer so that they could make appropriate referrals and navigate women to fully trained genetics professionals. And so our target trainee participants, which we've abbreviated CORE P, just something we made up, but community health educators, promotoras, lay health advisors, or patient navigators. Sometimes these individuals who are working within the community are also called community health workers. Requirements for our training program are that they are bilingual in English and Spanish and engaged with the Latino community. And we know from other work that individuals who are community health educators or community health workers have been very effective in improving cancer screening in different populations. And that, again, there was strong interest in building these bridges between genetics professionals and the community. And so here are the goals of Árboles Familiares: to increase trainees' knowledge about genetics, again, their understanding of what happens during genetic counseling and information about the genetic testing process, and then build that self-efficacy or their confidence in identifying individuals who are at high risk. And we have a two format training plan that consists of in-person workshops and online modules, although during COVID, we had a completely virtual version. So individuals who are interested in the training program apply and complete a baseline survey. Then we have 2 introductory modules, a very global overview of Genetics 101 and Introduction to Hereditary Cancer. Then we have our in-person workshop. And again, we were just able to redo this in November for the first time in a while, but it's a 2.5-day kind of intensive in-person workshop. That's followed by online learning modules. We ask that all of our trainees apply what they learn through what we call the action project. And so that's application in the community. That could be an educational session, development of a navigation guide, development of a referral list to genetic specialists in their community. And then we've asked them, how are things going? Have you been able to educate women or individuals at risk for hereditary breast and ovarian cancer in the community? And have you referred anyone? And we ask that at 6 months and 12 months. And throughout the next few slides, there'll be some quotes on the slides that come from some of our trainees. So in terms of the training itself, we have a variety of different learning methods. Again, the pictures you'll see are pre-COVID. You'll see some with post-COVID with our masks on from November. But we have lectures and videos, a lot of small group discussions. We play games to help apply the information. We have role plays and mock sessions, and then different types of learning sessions. And we have made changes over the delivery of these different cohorts based on our participant and trainee feedback. In terms of the online training, we ask that participants do this every 1 to 2 weeks. We have a 30-minute recorded video lecture. They can also download the slides, and we ask them to complete a short evaluation after each one. And these are topics that focus on kind of the application of the information that they learned in the workshop and making it applicable to their community. So these include discussions about how to identify community members who are at risk, so reinforcing the identification of the red flags. As I mentioned, identifying local genetics professionals or services through existing web resources and local hospitals and clinics. Identifying how they might go about providing referrals and navigation to those genetic services, creating community guides as an example of their training project. And we have both synchronous and asynchronous aspects so that they could have questions answered or have a conversation with a genetic counselor. So far, we have trained 179 individuals from different states. The project is housed at Washington, D.C. We have a partner site at Icahn School of Medicine in New York, and then Moffitt Cancer Center in Florida. When we originally conceived of this idea, we were thinking we would cover the East Coast and a bit beyond the region, but we've had interest from all over, not quite every state where that's one of our goals. But we did just host that our most recent training in California because we had a partnership with the Latino Cancer Institute in California. You can see our trainees come from many different countries of origin, although they all are in the US at the time of the training. And almost half identify as community health educators or patient navigators. We found that many of our trainees identified in more than one role within their organization. In terms of demographics of our trainees, most are women. We welcome men or individuals of non-binary gender to apply, and different reported and identified races. Largely, our ethnicity is Hispanic, given our focus on bilingual, and then differences across our trainees in terms of language preference. To date, we've been really excited that all of our trainees have indicated that they've educated some community members about hereditary breast and ovarian cancer. Not quite 2/3 have reported that they interacted with a healthcare professional about hereditary breast and ovarian cancer. About half thus far had identified a patient or community member at high risk, either one or more. And then 44% indicated that they've navigated at least one person or more to genetic services. We also have seen significant increases in knowledge and self-efficacy or self-confidence, as well as in genetic literacy between our baseline and the follow-up. And so some of the lessons learned so far in our work, starting with the telegenetics and telephone genetic counseling, is that it appears to be a quite viable option for reducing barriers to access of genetic counseling. I think we saw that, over time, not only during COVID, but also before COVID. I think telephone genetic counseling has been becoming much more common. And if there's any genetic counselors on the line, would love to hear about their experiences with that. There remain some barriers related to access for genetic testing, and that includes accessing the ability to have the test itself, particularly if genetic counseling was delivered via telegenetics. We've considered a lot of different options, mailing saliva kits with videos of how to provide a quality saliva sample, in the telephone genetic counseling study, kits were mailed to individuals, and then they took it to a laboratory in their neighborhood or area in which there was a blood draw. So there was a, the paperwork associated with how to do that. One thing we've considered and started doing is for individuals who choose to have genetic testing to have another appointment by video to then help guide them with the process of providing a sample and then how to get that sample in the mail and return it. And then in our more recent work, a strong level of interest among individuals who are already working out in the community as community health educators or patient navigators in terms of expanding their knowledge and skill sets to identify individuals who are at high risk for hereditary cancers. I think the model that we have for Arbolace familiaris, although focused on hereditary breast and ovarian cancer, could easily be transportable to other hereditary cancer syndromes. Right now, our workshop, we've delivered it virtually. Overall, we're still in the process of we're just about to launch our 6-month follow-up of our first virtual cohort. So we'll see how they do in terms of their knowledge and improvements in genetic literacy and the like to see if it's comparable to in-person. For our population, with individuals serving the Latino community, there does seem to be a interest in having in-person training to be able to connect with one another. And you'll see some of the pictures here. We have one of our case studies is we have small teams go through a pedigree. So they draw the family history and then they present a case to the group. We do candy DNA activities where they create double helixes out of candy during the Genetics 101 lecture, and then the small group activities. So I'm again, really honored to be here today. Thank you so much for your time. I think I see something in the chat and very happy to have any questions or hear about your experiences related to telephone genetic counseling or working in the community to help raise awareness of genetic services. So I can, and a big thank you, of course, to our team, our trainees, and then this is the team for our Arbolace project. So I can stop sharing now. And I do see that there's something in the chat. Oh yes, so thank you. This was a question about the background country of origin and acculturation of the Latinx community. So for our formative work, we do have some of that information. I'm happy to share that and follow up. And then I presented on some of the countries of origin of our trainees as well. But happy to talk more about that question if there's more questions.
Okay. Well, thank you so much. And I have a couple questions here to kick off, and maybe you can give us your impressions. But to begin, what do you see as the primary challenge for genetic services in rural Appalachia? I know you don't routinely work there now, but maybe you have some ideas based on your previous work.
Sure. I think some of the barriers are exportable to different communities. So in rural Appalachia, I think the number and location of genetic professionals, specifically genetic counselors. I think we need more genetic counselors overall in this country. And then making sure that community-based clinics have access, if not in-house, then access to a genetic counselor, ideally by something like telephone, so that individuals who are identified as having potential risk for hereditary cancer syndrome can be connected directly without having to travel. And, ideally from the comfort of their own home or from the clinic itself through telephone or through video. So I think a number of genetic counselors is one barrier. And then access to the testing options. I think that is changing with provision of buccal kits and the opportunity to mail those in. I think a little bit about some of the direct to consumer testing, and if people can do this for fun, then we should be able to do this for healthcare. So those are some of the barriers that I see. The other piece is, conversations about cancer and conversations about risk factors and conversations about cancer in the family. And in some communities, there may be taboos about talking about specific types of cancer or a strong family history. There could be also a sense of, well, that's just how it is in our family, without knowing that there could be information that might be of interest to some family members to indicate if they carry these genes that might be putting them at greater risk for having a hereditary cancer. So I think those are some of the pieces: awareness in the community, discussion of cancer in the family, lack of genetic counselors, and then logistic barriers to genetic testing, which includes cost or insurance as well.
Okay. And so by the same token, what do you see as some potential opportunities? I mean, you've talked a little bit about some of your work, and maybe there would be some relation of that.
Mm-hmm. Sure. So I think in rural communities, building on some of those community ties in the settings in which people are receiving some sort of healthcare, so that, if there are individuals who could start to have those conversations about cancer in the family or age at diagnosis. So those could be individuals at community clinics, implementation of some family history taking in a systematic way. And some of the clinics we've worked in, they do that, but then there's sometimes a disconnect between what happens in terms of if people are checking, I have a mother and a sister with cancer, it doesn't always then result in a referral to a genetic counselor. So I think that's starting to change, but implementing some of the workflow systems to translate identification of red flags into a referral, I think is one of the barriers that we need to overcome.
Great, thank you. Any other questions? So I think Marina was quite interested, but she had to leave. So I understand that this is lunch hour for some folks. So appreciate that. Well, thank you for a wonderful talk, Dr. Graves. And I enjoyed it and learned, even though I'm familiar with your work, I learned a little bit more today. And it's got me thinking about some of the opportunities there. And certainly previously in our sessions, the idea of kind of informational aids and that decision aids and that kind of thing has been discussed. So I think there is a fair bit of interest in that among the group. And some of the folks that had mentioned some interest haven't been here, but hopefully they'll hear this. They'll hear this on the recording. And there's a follow-up from Dr. Galvez. So, and she is interested in pharmacogenomics.
Oh,
So,
great. I'll put my email in the chat, and if anyone thinks of other questions later, please feel free to reach out to me. And I think there's a lot that we can do out in our communities to raise awareness about hereditary cancer and genetic services. So I applaud each of you for doing the work that you're doing and for your interest.
Well, thanks so much for your talk today. And we have our evaluation survey link posted in the chat, and we appreciate folks giving us feedback and that certainly helps with our funder, and to let them know if this is the kind of thing that we need to work on. And I'm hearing a lot of discussion in different groups about trying to address this issue. So next month, I will be presenting on some of the data from our session, kind of as a wrap up, and appreciate anyone that can come and contribute and discuss how we might plan to move forward. But we've got a lot of great ideas, both from the initial intake whenever people registered for the sessions, as well as during each of our speakers, and ways that we might approach. So again, thank you all so much. And if there are no questions, then I'll just thank you again, Dr. Graves, and look forward to seeing you next month.
Thank you so much for having me, and thanks for organizing this great series. Hope everybody has a good day.